Second hour is going to be on colon cancer, and I promise by the time we are done, you guys will be oncology pharmacists. Are you ready for that? Okay, well, some of you, or most of you already know me. I know it's been virtual, in person, here and there. But again, my name is Dr. Ajewole. I am a proud CSU alum, graduated 2015, so I used to be in your same seat, same setting. And finished my, graduated 2015, went on to Methodist Hospital to obtain my residency training for 2 years, where I focused in oncology. And I've had the privilege to be back in CSU since 2017, present students, residents, and have opportunities to work on several grant-funded initiatives. So I've seen several of you in different classes, outreach, different things. So thank you for staying engaged, and I'm excited to see you all move forward, become P4s, graduate, and do all the great things that you have ahead of you. This morning I have with me Jenny. Jenny, say hi to the class. Jenny is one of our staff. She is a graduate of Health and Human Physiology from the University of Iowa. She's one of the staff in our Advanced Health Equity program. She's just getting in to learn a little bit about prostate cancer because she's going to be creating some infographics about prostate cancer for us. Okay, the only update I have made to the prostate cancer slide, one of the slides was not fully updated, and I will tell you when I get there, but I've updated that in Blackboard last night. So whatever I posted last week, there was a slide that was in red. I fixed it and I have that information updated. Okay, so let's go ahead and get started. Today we'll just review the background of prostate cancer. We're going to discuss some treatment options in prostate cancer. And also, if time permits, because I'm looking at the time, we will talk about supportive care options and survivorship plan in prostate cancer. My goal is to get you guys the knowledge that you need to be successful in NCLEX, to be successful as an entry-level pharmacist, okay? I have 2 years of residency training, several years of clinical practice behind me. I am not going to transform you to being a board-certified oncology pharmacist in 2 hours, okay? So calm down. If you've had things about cancer, oncology is difficult, yes it is, it's challenging, but we'll break it down. We'll give you the necessary information that you need to be successful, okay? So let's look at etiology and pathophysiology. I always love to start from here. Prostate cancer basically begins when the cells in the prostate gland grows uncontrollably. Some people don't know where the prostate is. That is why I have included a picture there. Prostate is a gland that is only present in male population, biological male population, and I'm saying biological because we know transgender people are changing gender orientation. So just be mindful that if someone is given birth to as a male, they should have a prostate. And it's located behind the bladder and it's right above the urethra. So this is a picture of what the prostate looks like. Normal prostate versus the cancerous prostate. When we look at the numbers for prostate cancer, it's unfortunately the leading cause of cancer diagnosis in men in the United States. It represents 27% of all cancer diagnoses. That's a lot, right? 27%. So that's over a quarter of all cancer diagnoses is prostate. So are you going to see prostate cancer at some point, even if you're retail, even if, regardless of where you find yourself? Yes, you will, because it is very common. 1 in 8 men will be diagnosed with prostate cancer in their lifetime, generally. And when we look at African American men specifically, the number even decreases to 1 in 7, because African American men have a greater risk for prostate cancer. This is the second leading cause of cancer-related deaths, and you can see the numbers there. When you look at survivorship in cancer is pretty much considered anything outside of 5 years from the point of diagnosis. A localized disease, and we're going to talk about the stages of prostate cancer shortly. Localized disease, you're looking at nearly 100%. regional disease nearly 100% survivorship, which is great, but of course, as the disease metastases and goes out of the prostate, distant disease, you're looking at about 30% survivorship. So that is obviously not a good result. All right, so we're going to talk about some of the back-end biochemical basis of what feeds prostate cancer. Testosterone is considered to be the food or what drives the fuel that stimulates prostate cancer growth. Okay, that's why I have this picture here. You all remember basic anatomy and physiology. You know that from the pituitary gland, you have the LH, you have the ACTH, and it releases, the LH stimulates into the testes to produce what? Testosterone, right? When testosterone is produced, it stimulates the prostate. The second pathway is ACTH stimulating the adrenal glands that are on top of the kidneys. It stimulates the production of the adrenal androgens, which is a minor pathway for testosterone secretion. So when you're not thinking about how to decrease the growth of prostate cancer, it's almost second nature to say you're going to stop testosterone production, right? Because when you know that this is the fuel, you want to stop a vehicle from moving, then you disconnect the fuel. You don't fuel the car, right? So testosterone drives prostate cancer, and it's reasonable to say treatment option-wise, you want to do something to decrease, diminish, or decrease the impact of testosterone on the prostate. All right, looking at risk factors. Race is a risk factor, I said that earlier. African American population, unfortunately, they remain at a higher risk for developing prostate cancer, and it's less common among Asian population. Family history is also something to pay attention to. If a close family relative, first degree, it increases the risk to about 16%. There's genetic issues that have been identified, BRCA1, BRCA2 mutation, as well as Lynch syndrome. These are genetic related abnormalities that increases the risk for developing prostate cancer. Of course, older age, as we get older, the risk of prostate cancer development increases, as well as obesity. When we look at the signs and symptoms, just thinking back at the anatomic location of the prostate, right? It's located close to the bladder, so anything that impacts that area would obviously cause urinary symptoms. So men will start complaining of trouble urinating. There will be a decrease in the force of strain of the urine. Sometimes when you have ejaculation, there can be blood in the semen, and that is obviously abnormal. There can be some form of discomfort in the pelvic area. There are times where patients will complain of bone pain, and by the time the patient is complaining of bone pain, that tells you something. Then the prostate cancer has moved out of the prostate area into the bone, okay, because it's not causing issues somewhere else, and of course erectile dysfunction. So these are the common signs and symptoms. And with that being said, I've seen a lot of prostate cancer patients that they don't even have these symptoms initially. So there are cases where, okay, some patients will present straight out of the door with these symptoms, and there are cases where it's just incidental finding. They get on 59, they get into an accident, they end up doing a CT scan, and boom, you find something abnormal. So that has also happened before. Okay, then when you look at differential diagnosis, does anyone know what BPH is? Benign prostate hyperplasia? What is it?
Enlargement.
Enlargement of what? Prostate, okay. And does the sign and symptoms seem similar to what I said earlier?
Yes.
Yeah, so that's why sometimes you see that overlap, right? Up front, you're like, oh yeah, you've got BPH, you know, there's something going on. And of course, with male population, these are affect sexual intimacy, affect masculinity, so they tend not to talk about it. They just keep it to themselves, and unfortunately, by the time you explore what's going on, sometimes it'll be rather too late at that point. Other things to consider are chronic prostatitis, which is inflammation of the prostate itself, or sometimes urinary tract infection. Usually urinary tract infection is not a common thing in males, unless if they have a folate or they have a device in the urinary tract. But if a patient has UTI, then some of those signs and symptoms will be something that you will also find. So again, pictorial, I like pictures, I read and I learn with pictures, so you will see some pictures included on the slide for you guys. So we have the normal prostate, you have the enlarged prostate, and in a prostate cancer situation, the prostate will also be enlarged, but of course, by the time you palpate, by the time you do ultrasound, you will find a growth inside that gland. Make sense? Questions, comments? We good? All right. So when we look at diagnosis, how do we diagnose prostate cancer? There are a couple of options. The first option, which is quite uncomfortable for most people, for obvious reasons, is called the digital rectal exam. That is the first picture with the blue highlights on your screen. And as you can see, this involves a physician putting their digits, that means their finger, into the anal canal of a patient to palpate the prostate. Is that convenient? No? Right? Is that something you want to do? Is that something male patients want to do? No. So, but that is one of the main ways to diagnose prostate cancer. And of course, that also tells us to draw back, right? Because nobody wants to subject themselves to say, hey, females are more open because we have children, right? That whole process you get to be seen often, but most male patients are not comfortable going through that procedure. The alternate diagnostic strategy is using a transurethral ultrasound. So in this case, you are replacing the finger with an ultrasound device that you use to take pictures of the prostate to determine if there is any area of nodularity within the prostate gland. Okay, alternate is MRI, which is, pictorial. You take pictures using through the MRI machine. The other approach is PCA, which is more like a genetic screening option. Then the last one here is the PSA, and I'm going to talk a little bit about the PSA in the upcoming slide. But PSA is pretty much a blood draw. So you do a blood draw, and depending on the level of the PSA in the blood, there can be a determination if additional information is needed to confirm diagnosis, or if you want to say, okay, come back to screen in a couple of years. Okay? All right, so now let's talk about PSA. So the prostate-specific antigen is produced by the prostate cell, and it has a function of, making the seminal secretion liquid, right? With that being said, the PSA is specific to the prostate, but it is not specific for cancer. Does that make sense? So anybody that has a prostate can secrete PSA. So the fact that PSA is secreted does not necessarily mean that the prostate has cancer in it. So does that make sense, guys? Right? So because of that, PSA is typically done in conjunction with a DRE. Because when you do a digital rectal exam, you are feeling and palpating that gland. And if you're able to palpate any nodularity, anything that feels abnormal, then you want to do, some additional tests. But of course, DRE is not commonly accepted, so there is recommendations to using a transrectal ultrasound, and it is preferred for certain patients. For the most part, men greater than between the age of 40 and 50s, PSA greater than 2.5 is considered abnormal. Okay? If you have a man that is greater than 60, PSA greater than 4 is considered abnormal. And there are several drawbacks. What are those factors that impact PSA? Number one, finasteride, dutasteride, right? Do you all know what these drugs are used for? BPH. So you see that overlap again, right? So when we're talking of the differential diagnosis, BPH comes up. When you're looking at factors that influences PSA level, finasteride and dutasteride also comes up. Sulfamelto, retail workers, CVS, Walgreens. Have you all seen sulfamelto in your pharmacy? right? They use it, male else, blah, blah, blah. But guess what? It can influence the reading of the PSA. And of course, if you have recent intimacy, sexual intimacy, that can also influence the number of PSA that is detected in blood circulation. And if there is any form of manipulation of the prostate, either during a DRE or a biopsy, that can also impact PSA reading. All right, let's talk about the screening recommendations now. You all pay attention to these because as basic entry-level pharmacists, you should be able to have a reasonable conversation with people wherever you find yourself. As a clinical pharmacist, retail pharmacy, wherever you might be, about screening for a very common cancer like this, okay? I have included on this table several guidelines. The one that I want you to pay attention to is the NCCN guidelines. So put asterisks there, mark it up, cycle it all around. NCCN guideline is what we are going to use for discussions for prostate as well as for colon cancer that I'm going to talk about in the next hour. Essentially, we are looking at average risk patients, meaning they don't have a family history, they don't have any genetic abnormality, they don't have any inflammation of the prostate gland. The recommendation is to start screening at the age of 45. Okay, so pay attention to that. You're working at Walmart, someone walks up to you and say, hey, prostate cancer, I'm scared, should I start screening now? You should ask them, how old are you, right? Do you have any family history? Ask them those basic questions and be able to guide them as to what information might be needed. Then, one thing to note as well is that for high-risk patients, right? You see the asterisk at the bottom of the page. So high-risk patients considered African American, men that have first-degree relative diagnosed with prostate cancer at an age greater than 65. For those patients, you want to screen them at a younger age. Most guidelines will consider screening at the age of 40 if they are high risk. But otherwise, general recommendation, average risk patients is what? 45. We're good on that? All right. Staging, cancer staging. And I know I posted in Blackboard a couple of bullet points on things that you should review. So I'm just going to go through some information without going through the weeds because I expect that you should, have some of this basic information. But feel free to stop me. I don't want to lose anybody. Feel free to stop me as I go through. So when it comes to staging, question? We're good? Mm-hmm. All right. When it comes to staging of most cancers, the model that is used is called TNM. Okay? T stands for tumor. And tumor, you're looking at the size. How big is this tumor? N means lymph node involvement. When you identify a tumor, you want to look around that tumor area to see, do you have any lymph nodes that are involved? And of course, we know that our lymph nodes are the defense mechanism. They are part of the defense mechanism of the body, right? So if lymph node is involved, it means that that cancer has advanced a little bit more. Then the third is metastasis, meaning the cancer has actually migrated outside of its original place of development. So in this case, we're looking at prostate cancer. You're then looking at the lymph nodes around the prostate area, meaning the pelvic area. Then you're looking outside of the pelvic area. Do you have prostate cancer in the liver? Do you have prostate cancer growth in the lungs? Do you have prostate cancer growth in the bone? Do you have it in the brain? Right? Because it can actually migrate, it can move out of its original place. Does that make sense? Okay? And when you ask yourself, like, how, I see your hand up, when you ask yourself, like, how does it move? The blood circulates, right? Our blood circulates and touches every single cell. So the blood is definitely one of the vehicles to transport these prostate cancer cells from the prostate gland into a different organ in the body. Yes, question?
You kind of answered my question, but you would know that it's caused by the prostate because of the PSA in the cells. If you found cancer in the brain or whatnot, you would know that it came from the prostate because of the PSA?
Yes, great question. So let's say we find Mr. A, he got into a car accident on 59, we brought him in, they did a CT scan, and they found that he has some abnormalities in his bone, or they found some nodules in his liver. You don't want to assume that the nodules in his liver are liver origin, right? The only way to confirm is to do a biopsy. So biopsy basically means you put a needle into that organ, obtain samples of whatever you're looking for, obtain samples of that nodule, take it to the lab, they analyze it and determine the origin of the cell. So prostate cell will always look like prostate, even though it's in the brain. Even if it's in the liver, even if it's on the bone, it would always, like I'm always Veronica wherever I go, right? So the prostate cell will always look like. So even if it's in the liver, lung, bone, wherever, a biopsy will be done, and based on the result of the biopsy, they will determine the origin of the cell. Okay? Yeah. All right, I'm including this again for completion's sake. When you do the biopsy, like I was talking about, you would have this display to figure out how advanced is this disease. The first green layer, they are small, they still have similar conformation, but as you move further out, you see that it looks like, what are cells? You know, this does not look circular in origin, everything is just like mix up, hodgepodge type of a thing. So based on this, they also assign grades to the prostate cancer. So based on the T, tumor, N is for what? N, lymph nodes, right? So T and N and the glazing pattern, a stage is assigned to the patient. So you combine that T and N with the glazing score, then you'll be able to assign a stage to the patient. And staging is important because it determines the treatment that the patient will receive. Okay? All right, so here again are the stages for pictorial, those are the pictorial letters. So you have stage 1, meaning the cancer is still very confined to its original place of origin. That's within the prostate. Stage 2A, stage 2B. Then when you get to stage 3, you can see that it's migrated out of the prostate. And of course, stage 4, it's pretty much gone everywhere. All right, so I'm done with the basic updates, basic foundational information. Questions, comments before we talk about treatments? All right, so what feeds prostate cancer? Testosterone, good, okay. So for us to treat prostate cancer, what do we want to do? You guys are awesome this morning. Great. All right, so we're going to start from there. Ways to decrease testosterone production or its activity. So there are 3 main things that we can do. Number 1, we want to decrease testosterone production from the testes. And like I said earlier, the testis is the main zone. That is the major pathway for testosterone production. So you cut it off, decrease it from there. The second option is for you to decrease testosterone production from other areas, which in this case is going to be the adrenal gland. So you find another X right there. Then your third option is for you to block the activity of testosterone on the prostate cell. So you're basically doing 3 things. Number 1, decreasing testosterone production from the major pathway, from the testis, decreasing testosterone production from minor pathway adrenal, and then you are blocking the impact of testosterone on the prostate cell. Got it? Good? All right. Are you liking oncology yet? Scared, nervous? It's fun. I enjoy what I do. Hopefully some of you will join me soon, okay? I don't mind. Come join me. All right, so we're gonna talk about androgen deprivation therapy. Okay, I talked about reducing testosterone. So the goal of androgen deprivation therapy is to induce castrate level. You would almost never shut down testosterone to zero because we still need testosterone for other things. Our men need it for broad shoulders, the muscle, like six packs, all those good looks, masculine voice, the beards, all of that. So we still need testosterone in our body. But when you induce castrate testosterone level, your goal is that in the serum, in the blood, testosterone will be less than 50. Okay, so keep that, note that. You're gonna see it again. Your goal is less than 50. And there are two ways to achieve this. Number one, surgical castration, meaning they remove the testes surgically. Or medical castration, you give them medications to decrease the production of testosterone. Okay, and when it comes to medical, we are in pharmacy, right? We are the drug people. So we're going to talk about the drugs. There are two major pathways to do this. So you have the luteinizing hormone releasing hormone, LHRH, it's a mouthful. LHRH, you have agonists or antagonists. Okay, if you all remember physiology, anatomy, P1, maybe even pre-pharmacy years, does anyone remember LHRH? It's been so long ago. Remember. All right, so I'm going to start with the agonists. And when you look at agonists, right, in your mind, you're like, well, if I want to decrease testosterone secretion, I should not use an agonist, right? Agonist means you want to increase the level of activity, but guess what? Feedback mechanism. Okay? Did Dr. Milton teach you guys feedback mechanism? So feedback mechanism, you're going to initially stimulate the production of testosterone, but eventually you kick into feedback mechanism which will cut it off at some point. So there are four major drugs in that drug category of LHRH agonist. So those are listed for you. I don't do doses and dose interval at this point of your career, but if you come join me on my side, and we'll talk more about the doses and the interval because it matters. But for now, all I need you to understand is it an agonist, is it an antagonist, and what is the goal of the testosterone and why are we doing it? Because that will help you, right? You do less cramming, but more of understanding. That's how I teach. I teach for you to understand. There are times where you have to memorize, yes, but you don't do 100% memorization. One thing to note, like I said, with LHRH agonists, because you're going to increase initially, right? You will have something called tumor flare. Because you're going to increase testosterone production. So imagine you're firing it up. Then what's going to happen to the prostate cancer? It's going to keep growing. So initially, there's something called tumor flare. Okay, so I think I explained it. I don't think any of you would have to memorize that. I think you should be able to explain it too, because it makes sense. If it doesn't make sense, then read it again, knock on my door, send me an email, and we'll talk about it. Good? Keep going? All right. So the second class now are antagonists, which again, it makes sense. This one is just going to shut it down right away. With an antagonist, would you expect to have tumor flare? No. Exactly, it makes sense. Agonists would have tumor flare, antagonists, we don't have tumor flare. Easy, it's all good. Most recent one, most of all these LHRH agonists or antagonists are injectables, but most recently there is an oral formulation, Orgovix, that was approved, so it makes it easy. You don't have to bring them to the infusion center every 4 weeks or 12 weeks to give them a shot. They can easily pop a pill and they'll be okay. All right, the second option to androgen deprivation therapy or castration is bilateral opiectomy. And keep notes, it's not one because physiologically males have two testes So you have to make sure you take out both of them. So you're not just doing one, you are doing both, and it's complete bilateral ochiectomy. And with this, ground zero, pretty much, bring them almost immediately to ground zero. But there's still the adrenal gland, remember, right? We have the minor pathway, the adrenal gland can still produce testosterone, but you just have to be mindful of that. With these side effects, obviously impotence, as well as hot flashes. Okay, any questions on that? We're doing good?
Could they just remove one?
Can you repeat that?
Could they just remove one and the girl would be fine?
Remove both.
Okay.
It has to be both. Because if you remove one, then the other one is still gonna keep working. You still have the ability to produce testosterone. The only reason why you would remove one testicle is if a patient has testicular cancer. So if you have a patient that has testicular cancer, which is common in younger adults, unfortunately, then you can remove one and keep the other for retention of sexual functionalities and all that. And most of the times, we'll offer them fertility preservation because you don't want to risk it. Especially if it's young and they do desire to have children later on in life, then do fertility preservation before you remove their testicles. All right, so we're going to talk about subtypes of prostate cancer, and I hope that the background information I've given will help you understand what this is all about. So, castration-sensitive prostate cancer, what that basically means is we've given them LHRH, bilateral ochiectomy, whatever it is, and their PSA is quiet. That means it's sensitive to becoming castrated. Does that make sense? So you've made the patient castrated and their PSA is responding. So that is this caption of castration sensitive prostate cancer. This second one means castration resistant, meaning I have given them ABT, their testosterone is less than 50, but guess what? PSA continues to rise. Does that make sense? I don't see nods, I don't see yes. Are you confused? Go again, all right. Castration sensitive means you have castrated the patient. Testosterone is less than 50. When testosterone is less than 50, you expect the PSA to decrease because prostate cancer is no longer active. In those cases, you consider them castration-sensitive prostate cancer. But there are some cases where you have castrated the patient, but the PSA continues to increase. In those cases, you call them castration-resistant. Does that make sense?
Yes.
All right, cool. Then the other way to categorize, yes, question?
How do you say it? Would castration be the last method? Like, what would it be first?
You would do castration first.
Before medicine?
Medical, usually. Usually you do medical. So if previously, and I think I have it here, previously that was the gold standard because there were no medications available 10, 20 years ago. But now, thank God for pharmacists and pharmaceutical companies and research breakthroughs that people do have options of using the medication over becoming castrated. But there are cases where men are like, you know what, I will just go get castrated instead, like, take it out. Okay? All right, the second way to categorize prostate cancer is now, is it metastatic or is it non-metastatic? And we already know what that means. Non-metastatic means it's still within the prostate. Metastatic means it's gone out. It's in the bone, it's in the brain, it's in the liver, it's, everywhere else outside of the prostate. Okay, all right. So let's talk about the treatment stuff now. We're going to start with the non-metastatic castration-sensitive prostate cancer. And I'm going to focus on this part of representation of the table. Here, we start with observation, meaning you keep them castrated, you don't have to give them any other medication. All you're doing is just monitoring their PSA intermittently. Okay, that's the easiest, that's the sweetest spot to be. But not many patients are there, I'll be honest. But that's an option if it's available. Active surveillance, meaning you continue to monitor as well, but you monitor them a little bit more closely, maybe because of their risk, because of the type of procedure they had. The other option is for you to do radiation therapy. They will just, expose some parts of the prostate gland to radiation treatment. Benefits compared to surgery, they don't bleed, less risk for urinary incontinence, and you are able to preserve erectile function for some time. But there are disadvantages to it as well. The other option in this castration-sensitive realm is radical prostatectomy, okay? And with this, you are going to remove the prostate gland itself. That's surgical removal of the prostate gland. If it's appropriate, if all the tumor is still within the prostate, nothing has gone out, then you can do radical prostatectomy. And you only do this if you know the patient has a longer projected survival. You probably not do radical prostatectomy for a 70 or 75-year-old male when you know they won't be around for too long. You see what I'm saying? Then there are complications, because incontinence is definitely going to be an issue, impotence is going to be an issue, but there are ways around it. Have you guys done erectile dysfunction yet? At some point, did you already do erectile dysfunction?
Yes.
Okay, so you can go back to review some of those medical interventions or even mechanical interventions, because for prostate cancer patients, we do use some of those to preserve erectile function, depending on the type of procedure they received in the past. All right, so pretty much non-metastatic castration-sensitive prostate cancer, we don't use drugs. Observe, active surveillance, radiation, and surgery. That's where it stops. Okay? Now we're going to talk a little bit about those that are castration-resistant. Question, yes?
So the medication is the first line. With those previously, which one is considered a second line? Are they considered second line or just an alternative treatment for surgery?
So in this realm of castration-sensitive prostate cancer, we don't use any additional medication. The only thing you do up front is withdraw testosterone secretion. Keep them castrated. And once they are castrated and their PSA is responding, you don't need to use any medication. Okay? But now when you advance further into castration-resistant prostate cancer, you start using medications, and that's what we're talking about. First line, second line, and all those type of treatments.
No, what I meant is the methods, what you just mentioned, like the radiation.
Mhm.
Which one is more preferred?
It depends on the overall risk of the patient. Yeah. So it depends on their PSA initially, it depends on, the size of the tumor. So that's a decision that the surgeon, the urologist, and the patient will have to look at it and see which one is best. But typically, we wouldn't do medications in that case. Okay?
Thank you.
Sure. All right, so castration-resistant prostate cancer, now we're looking at medications. 3 medications here, they kind of sound alike, right? And with amide. Right? So they are all within the same drug class, and we're going to talk about that briefly. For the most part, these medications are considered anti-androgens. And with this, you are looking at blocking the effect of testosterone on the prostate. Remember, we've already given them, they're already castrated, right? Their testosterone is less than 50. but their prostate cancer continues to grow. So what you want to do now is decrease the effect of testosterone on the prostate cancer, on the prostate cell itself. So these are considered generally as anti-androgens. So single therapy with anti-androgen is not as effective, but sometimes you use them for tumor flare. When do we have tumor flare? When we have agonists, right? LH-RH agonists, yes. So when you have LH-RH agonists, you can use some of these medications to prevent tumor flare. That's pretty much where you will see this flutamide, Casodex, and all these other ones that are listed here. The second generation anti-androgen receptor antagonists are three major agents. So you have apalutamide, darolutamide, and enzalutamide. Those are the three agents that we'll talk about more, and for you guys as pharmacists, you will need to know a little bit about these medications, okay? The first one is apalutamide. The good thing about this is that it's an oral medication. This is what I do. I practice in oral oncolytics. So the patients that I see every day in the clinic, they have different types of cancers and they're taking oral chemotherapy. So apalutamide is an oral chemotherapy. So they don't need to sit in the infusion clinic, they don't need to get an IV, they just come in and take their oral medication. This binds directly to the androgen receptor. It inhibits androgen receptor nuclear translocation, and basically it impacts the effect of testosterone on the prostate, basically. Important things to note is the dose on here. Recommended dose is 240 milligrams once a day. And canceling points, we can't get away from that. This should be taken with or without food. It should be swallowed whole because it's an oral oncolytic medication. And the patient needs to continue their androgen deprivation therapy. Okay, they need to remain castrate. You need to continue giving them the medication to keep their testosterone level at less than 50. So those are important information on apalutamide. This here I've also included for side effects control. They can have issues with, blood glucose, triglycerides, cholesterol, and these are ways to monitor or manage some of these related side effects. The good thing about most of these oral oncolytics is that it's not as toxic as some of the intravenous chemotherapy, so it's easier to manage depending on the case. So you're not seeing me talking about nausea, they're not losing their hair, right? When you get chemotherapy, those are the things you normally think about. Oh, hair loss, nausea, change of skin, their nails falling off, all of that. But most of these oral oncolytics are a little bit different. Okay? Again, apalutamide can cause a little bit of fatigue, so just informing patients to take it easy the first few days. And because this medication is something that they will continue to take pretty much for a lifetime. So this is not a hit and run. Once you start on it, unless if the disease progresses, to your question, first line, second line, right? If the disease progresses, then you would consider an alternate therapy for them. But upfront, they start on it and they remain on it, unless if the disease progresses or they cannot tolerate a side effect of the disease. So typically I say until disease progression or unacceptable toxicity. So it's only outside of disease progression or unacceptable toxicity, pretty much they will remain on this for a lifetime. All right, the second oral agent is darolutamide, and this is the slide that I updated. I've already made that update on Blackboard, so if any of you had downloaded the slides before, it was in red font because I was going to update and I didn't make that update when I uploaded it to Blackboard. This is the updated information, and that has been posted on Blackboard. The dosing on this is 600 milligrams, and this needs to be taken twice a day. The important thing to note is darolutamide, you take it with food. Apalutamide, the guy we talked about previously, you take with or without food. With this one here, you need to take it with food. Otherwise, everything is pretty much the same. When it comes to, swallowing as a whole, continue taking androgen deprivation therapy. Okay? Again, some side effects, how those can be managed. I won't spend much time on that. The third medication is enzalutamide extended. See, they all sound alike. Apalutamide, darolutamide, enzalutamide. This one is usually taken as 160 milligrams once a day, and this can be taken with or without food. So of all three, darolutamide is the only one that should be taken with food. All the other ones with or without food. Taken once a day until disease progression or unacceptable toxicity, and the possible side effects are listed here. All right, questions, comments before we talk about some other treatment stuff? You all are good? Sinking in? All right, let's keep going. The last set I'm going to talk about is the metastatic type of disease. At this point, patients has remained castrated and they have progressed. To your point again, right? They've progressed. They started out, the prostate cancer was confined in the prostate gland, but now it's moved. So now we also need to move our treatment to catch up. We're gonna play catch up with the disease. And there are times where straight out of the door, the patient is diagnosed with metastatic cancer, straight out of the door. Like initial diagnosis. The first day they showed up, they already had metastatic disease. So in that case, they will fall straight into this category. All right, the third class, if you all remember that slide that had the 3 X's, we talked about the first X, right? Where you diminish testosterone production from the testes. We've talked about the testosterone effect on the prostate cancer. That's the androgen receptor antagonist. Now we're going to talk about testosterone production from the adrenal gland. Okay, so that's another drug that we've not talked about yet. This drug is called abiraterone. It's also an oral medication, and this inhibits the CYP17 enzyme inhibitor. It inhibits the CYP17 enzyme. And with this, it disrupts androgen production. Knowing that testosterone is the main androgen that is produced in the adrenal, there are other androgens as well. Who knows any other androgen or androgen-like hormone that the adrenal secretes? Huh?
The ones we just went over, the liver ones? Androgen?
Besides testosterone. Cortisol. Yeah, cortisol, glucocorticoids. So when you block this enzyme, you are blocking everything. So because of that, you need to give your patient prednisone. Otherwise, they would have adrenal insufficiency. So every time you see a patient on abiraterone, you need to give them prednisone. You need to give them some steroid, because abiraterone is blind. It's going to X out steroid production completely. But your patient, they still need steroids to wake up and come to class. If your cortisol is not, it maintains your circadian rhythm. Actually, you wake up and sleep, otherwise you're awake all day and sleep all day, everything is messed up. Have you seen patients on steroids before, long-term steroids? They can't sleep because they are constantly stimulated. And if you don't have steroids, you can't wake up either. You just get sleepy and drowsy, and there's no energy. So, when you give a patient abiraterone, you must follow that with counseling points, these should also be taken on an empty stomach. Okay, darolutamide you take with food, right? Apalutamide, enzalutamide with or without food. Abiraterone, empty stomach. And when we define empty stomach is defined as good. Yeah. So making sure that the timing to food matters. 1 hour before or 2 hours after a meal. 1 hour before. And keep in mind, this is something that they take for the rest of their lives, right? So you want to make it really practical. And not say, hey, take it 6 a.m. every morning. They will forget. It's not an antibiotic, 7-day course. No, this is forever, pretty much. All right, and for this one, you should also adjust for hepatic dysfunction. All right, more information here about side effects. Okay, I'm gonna switch gears up, move up the step a little bit and talk about cytotoxic chemotherapy. Are we ready?
Yes.
Is everyone following me?
Yes.
Yes.
Good? All right, we move. If you all remember this, I taught you guys in P1 year, this picture or this slide is exact as what you saw in your P1 year, 2 years ago. So chemotherapy agents are basically designed to be blind, but they kill rapidly dividing cells wherever they come from, pretty much. Just think of it that way. All the things we've talked about before, they are quite specific. They are targeted, right? We're talking about testosterone, we're talking about adrenal, we're talking about, all these things. When you come to big chemotherapy agents, they are quite blind for the most part. But what you're looking at is they work against rapidly dividing cells. Do cancer cells divide rapidly? Yes, they do. So in working against cancer cells, they also impact other cells in the body. So that's why you see the hair falling off. That's why they have blisters in the mouth. That's why the nails get chappy. That's why the lips, nausea, vomiting, everything in between. Okay? Chemotherapy dosing. Do you all remember this? Okay, it's coming back. If you enjoy seeing it, come to my side. Okay? It's fun. I enjoy what I do. And speaking of that, in reality, I don't do these calculations every day, right? Because Epic, which is a system that I use, does it for us. That's reality of pharmacy practice. But for your leaflets, you have to do it. Because you have to know what you're doing, right? You just don't rely on the computer. If your computer acts haywire, you need to be able to there is no way my patient will have a BSA of 1.1. You should be able to, because what you put into the computer is what is going to spit back out to you. You understand what I'm saying? So I can't see a physical patient that looks like me and want to dose them on the BSA of 1.1 and know something is wrong. But if I don't understand the basis as a pharmacist, I won't be able to catch it. So no punishment is intended for good reasons. Okay, so these formulas are back, and we have an example to walk through in colon cancer. I am looking at my time, so hopefully we'll be able to do that. The real drug here, within the context of cytotoxic chemotherapy for prostate cancer, is just one. It's simple. It's called docetaxel. So last line, you've tried everything. You've done surgery, you continue to keep them castrated, you've done abiraterone, you've done enzalutamide, you've done apalutamide, you've done everything. And they still continue to progress. Then you give them the bigger gun of docetaxel. This will be dosed 75 milligrams per meter squared every 3 weeks, so they get it once in 3 weeks. It's an intravenous infusion. And this basically works on the microtubules And like I said, it's a blind cytotoxic medication. It works if you're rapidly divided. These things to consider are that it causes hypersensitivity. So you have to be very careful to make sure that you pre-medicate your patients, give them enough steroids. And when you give them steroids, they can retain fluid. They can get puffy, all around, but you just manage the expectations for that. That's pretty much the end of medication-related information in prostate cancer. There are other slides that I have included, but I'm looking at the time. I won't be able to cover those. But I encourage you guys to read through them. Because again, 27% of all cancers is what? Prostate cancer. I bet you in your career, you are going to see several prostate cancer patients. You might not see them the way I see them because they are coming to the clinic for their treatment, or you see them because they need help managing impotence. They need help managing hot flashes. They need help with other things. So, survivorship is very important because this is what for a lifetime when it comes to disease management. So osteoporosis, you guys have done that before. The recommendations are listed here. Diabetes and heart disease, the same thing. You guys have done that before. Recommendations are listed here. Bone metastases, bone pain, the recommendations are included here. Sexual and urinary dysfunction is a real thing for men that have to live with prostate cancer or prostate cancer survivors. So making sure that we are well equipped to take care of this set of patient population. All right, the last thing I want to mention, now that I'm thinking about it, when we use the LHRH agonist or antagonist, when you reduce testosterone, right, patients will start having hot flashes. So that's something else that it can come up to you for, because you're messing up with their hormone regulation. So hot flashes and things of that nature are things that you might see. All right, questions? We got it done in less than maybe about 50 minutes. Questions, comments? You all are good? Yes?
Yes.
All right, so I think we can take 4 minutes and stretch before we talk about colon cancer. All right, stretch around, guys. 4 minutes.